Uh, yes, okay. So, without further ado, I want to introduce our first speaker. He doesn't need that much of an introduction. Professor Medhat Sabahi is an associate clinical professor of Gulf Medical University and chair of section on psychiatric rehabilitation, part of the World Psychiatric Association, and the consultant psychiatrist currently in Ream Neuroscience Center. He will be presenting us a very interesting and very much weighted, sorry for raising the ceiling for the expectations, Dr. Medhat, lecture of psychopharmacology for the dermatologist. The floor is yours. We're looking forward to you, Dr. Medhat, and thank you once again.
Thank you very much, Dr. Muhammad, and thanks, Dr. Dimitri, for your very persistent initiative. As always, you are doing all your best to uh, raise awareness about psychodermatology, and uh, we are now almost more than 12 years uh, uh, in this uh, initiative that you are trying to have it, and I'm quite sure it will be very successful as always. I'm going to, as we were talking before, the colleagues joined, that I'll do my best to be very brief so that we have some floor for questions. And if I can answer them, I'll do my best. Psychopharmacology actually is not an interesting it's topic, because usually it's uh, talking about medications is not like as it used to be for the clinical cases, that which are more might be more interesting than just mentioning medication. But it's one of the tools that we are using in our work, is that we need to know about those medications that we might use for helping our patients. Uh, so uh, I'm sure all of you know this better than me, but sometimes that we need to uh, know about some of the basic pharmacological principles, like the half-life, which means that it's the time needed to clear 50% of the drug from plasma. The steady state, when it's reached, it's usually it's 5 times the half-life, and it's where the in and out of the medication is almost the same, and the total concentration of the drug in the plasma that will not change as long as the dosing rate remains unchanged. Of course, metabolism is there are lots of ways where the psychotropic medications are metabolized or chemically altered, or prepared prior to elimination. Of course, the hepatic metabolism, where the oxidative metabolism is done. All of us know about cytochrome B450 enzyme system that affects many of the drug-drug interaction of medications, especially in psychotropic medications, where because of this uh, competition on the cytochrome B450 system, some of the medication plasma level are higher or lower. So maybe we will put that in consideration when we are giving the medication that it might interact with others. In this case, we might increase the dose of some of them, or decrease it for others, so that will not reach a toxic level. Also, this is the phase one, and the oxidative metabolism, and phase two, the conjugation reactions. Again, the stage of elimination, uh, which is the clearance of the drug from the body. Most psychotropic medications are eliminated by the kidneys. but already has been converted to metabolites by liver. Sorry. Um, of course, therapeutic levels, there are some therapeutic range that might be uh, uh, where the medication, if beyond this, it might be, if less, it might be ineffective, and if higher, it will be might be toxic. And we will see in the coming slides that there are some of the medications that might need to be monitored to have their therapeutic levels in that range and the plasma levels in the blood. Uh, so talking about the neurotransmitters, I don't know, this is very busy, and we all know that there are certain neurotransmitters that are modulating our behaviors. And talking about those, we might talk about serotonin, norepinephrine, dopamine, and histamine, and as well as acetylcholine. In serotonin, there are so many types of serotonin, but the most known are serotonin 1A receptor, and in this case, when this receptor is stimulated, it has antidepressant effect and anti-anxiety effect. That's why many of the SSRIs are working as antidepressant and anti-anxiety. Serotonin 2 receptor, also this, if it when it's stimulated, it might lead to agitation and anxiety or akathisia, insomnia, myoclonic jerks, and sexual dysfunction. And when this receptor is stimulated by SSRIs, that's why you might find in some cases there are some sexual side effects with some of the SSRIs. Serotonin 3 receptor, and this is mostly present in the GIT system, and that's why SSRIs might have their nausea and diarrhea or gastric upset in the beginning of their introduction to the patient, as well as headache. The second neurotransmitter is norepinephrine. When it works centrally and peripherally. Centrally, when it's stimulated, it's have an antidepressant effect. If activated, it might lead also to some anxiety symptoms. While if peripherally, if it's stimulated, it might lead to increased blood pressure. If inhibited, it might lead to orthostatic hypotension and reflex tachycardia. Also, dopamine, centrally, if it is stimulated, it might lead to agitation, aggravation of psychosis, and a decrease in sexual dysfunction. But if it is inhibited, it might lead to treatment of those symptoms, that's psychosis and others, but it will lead to extrapyramidal symptoms as well. Histamine, all of us, we know that when it's inhibited, it might lead to gain weight and sedation. Acetylcholine, which is muscarinic receptors, when inhibited, it leads to blur division, dry mouth, and sinus tachycardia and constipation. So I know this is a bit very busy slide and very tough talk about receptors, but it's needful because these are the receptors that our medications are working on while we are managing different psychiatric disorders. So if we're talking about the classes of psychotropic medications, we have main groups for they call antidepressants. Actually, word antidepressants are not a very correct name because Uh, it gives the impression that those medications are working as only antidepressants, while it might be used in many disorders. And for example, if we're talking about SSRIs, uh, usually we talk about anxiety and depression, but there are some uh, disorders that might be treated like trichotillomania, for example. One of those and impulse control disorders might be treated by SSRI as well. But for the sake of categorization of medications, so they put it under groups like antidepressants, antipsychotics, mood stabilizers, anxiolytics, psychostimulants, dementia medications, and anti-Parkinsonian drugs, as well as the substance dependence management medications. Uh, if we are talking about, please, if I'm fast or you need to ask any question, if the chair allows, we can ask and I'll try to answer in the middle. Or as Dr. Muhammad uh, advised, if you want to answer questions at the end, I'm totally open for any of your choices. Sorry.
Thank you so much, Dr. Madhat, for the recommendation. So I think you can go on, and anybody who has any questions can put them in the chat box, and we can gather them all at the end of your talk. So take your time, and
And
we're
if
just
I'm fast,
enjoying it.
please break, put some breaks for me if I'm very fast.
Actually, I think it's perfect. Thank you much. Thanks so
Okay,
much.
thank you very much. So talking about antidepressants, antidepressants are divided into many groups. Historically, if we're talking about historical, the first of those medications was discovered was amitriptyline. And later on, which is one of the tricyclic antidepressants, and later on, the rest of the group are there. We have amitriptyline and colomipramine and imipramine. These are the tricyclic antidepressants. Uh, the three of them are available in Emirates. Talking about the secondary tricyclic antidepressants, unfortunately, it's not available in Emirates. Zipramine and nortriptyline, both of them are not available in here. Talking about the later discovered medications are the monoamine oxidase inhibitors or MAO inhibitors. And these are two medications, phenelzine and phenylcypromine. And both of these medications are rarely used now and rarely found because of its interaction with many other foodstuff and alcohol and these things, and it leads to hypertensive crisis. So it's almost not available in the market anymore. Uh, there is one of the a new generation of MAO inhibitors called RIMA or reversible MAO inhibitors. These are less side effects, and it's only one medication called Ororex, but it's not available as well. Uh, the most common and most known group of antidepressant is the SSRIs, which was uh, very public to the people since the mid 80s. And it was the first of them actually was fluvoxamine, followed by Prozac, which is fluoxetine. And later on, the rest of the group is available. Fluoxetine available here under the name of Prozac, paroxetine under the name of Siloxat, sertraline as Zoloft, fluvoxamine, Favarine, but it's not that available. Favarine specifically is having too much drug-drug interactions, and that's why, and the sedating, and that's why it's almost not available in MRs nowadays. Citalopram and escitalopram, both of them are available. Citalopram under the name of Cipram, and escitalopram under the name of Cipralex. I believe most of you are working in uh, private sector and usually, sorry, in the governmental sector, and in the government sector, usually you write the uh, scientific name of like fluoxetine or paroxetine, not the uh, trade name. Uh, then uh, I'd like here it's not shown in this slide. The there are two other groups of antidepressants. The SNRI and SNRI are a group of antidepressants that works both on serotonin and norepinephrine. And this group are three medications, uh, duloxetine or Cymbalta, and the other one is Effexor or venlafaxine, and the third is modified venlafaxine, which is this venlafaxine, and its name here is Prestige. These three medications are under the group of serotonin norepinephrine reuptake inhibitors or SNRIs. Also, there is one medication that works on dopamine, which is Wellbutrin or bupropion, and this is very helpful for uh, and anxiety and depression, but also it's helpful for smoking cessation. So it might be used for smoking cessation as well. One of the also uh, that might be different, but it works like SNRIs called mirtazapine or Remeron, and this belongs to a group of medication called NASA, and this Remeron actually uh, have antidepressant effect, but it has two side effects that might be used by us for subgroup of patients where they have difficulty eating or difficulty sleeping. So giving them Remeron or mirtazapine is helpful for initiating sleep and uh, increase their appetite. Some patients, especially patients who are suffering from depression, uh, lose their appetite and they have very interrupted sleep. So sometimes we might add Remeron for that. Also, Remeron might be added to potentiate the effect of SSRIs or SNRIs as well. If antidepressant effect is not enough, then we can add one of these, the Remeron to one of the other medications. Then the other group is the mood stabilizers. And the mood stabilizers, we use it, of course, might be used in some disorders like bipolar disorder. And in bipolar disorder, we have subtypes, like we have bipolar disorder with mania, or bipolar disorder. I'm trying to be very brief about this. Maybe we can talk about disorders in another session. But if we're talking about bipolar disorders, we have bipolar 1 disorder where it's alternating between depression and mania, or we have bipolar depression where there is a recurrence of depression mostly. Periodically, they have attacks of depression. And maybe it's mostly most of the patients who are suffering from bipolar, most of their time is suffering from depression. Even if they have bipolar 1 disorder, yet depression is one of the most recurrent attacks. Usually, the manic phases are very brief. And talking about bipolar mood stabilizers, it might be given to according to the disorders that they have. Like, for example, if we're talking about bipolar 1 disorder, where we have manic phases, we give mostly lithium or dipakine or valproic acid. If we're talking about bipolar depression, mostly we give lamotrigine and carbamazepine if possible. Uh, Usually, we are not giving gabapentin, Neurontin, topiramate or Topamax. Only we give in very rare cases, but usually psychiatrists don't give gabapentin because of its addictive possibility. So if we're talking about lithium, for example, it has lots of side effects and it needs to be monitored. And we need to do some blood test before starting giving lithium. And we need to be sure that they are taking enough water and they are not sitting in a hot weather because usually it might lead to some sort of it has a diuretic effect. So if they are losing their water and they are and it might cause some increase in the basal temperature of the patient. So it's advisable not to sit in the sunny places or in the hot weather. Uh, so also we need to check for the thyroid before starting giving lithium, for the kidney status before giving this. And Also we need to do monitoring for the blood level of lithium because it has a very narrow toxic level windows. So usually we give uh, the tablets of lithium to reach a level of zero point 0.6 to zero point 0.8 in the blood. But if it is more than 1.2, it might be toxic, and we should take care of this. And there is some algorithm for doing uh, monitoring for lithium, especially in the very beginning. We need to start with uh, after 3 months to check the level, and then after 6 months, and then later every 6 months we need to check the level of the lithium, and we need to educate the patient about the possibility of toxicity. If it happens, there are some physical symptoms like tremors, like uh, heart rate changes. So we need to educate the patient about these things so that if they notice any of those symptoms, they should see the doctor to check the levels. Also, we need to avoid the diuretics that has some drug interaction with lithium. Uh, of course, those mood stabilizers are used cautiously by psychiatrists. Some of them are anticonvulsant, like valproic acid, carbamazepine, gabapentin, and lamotrigine, and Topamax. All of these are uh, anticonvulsant, and we need to uh, be sure that the patient is not, if she's a lady, we need to be sure that she is not planning for pregnancy, and if uh, she is planning to have a baby, then we need to think about something else because of the possible side effects that might happen to the fetus because of these medications. Again, also most of them, like valproic acid and tegretol, their therapeutic window should be monitored by plasma level. And also we need to check for the CBC and the liver function test, and also and carbamazepine, we need to check for liver enzymes because it's usually it induces liver enzymes, and it might lead to sort of granulocytosis. So it's very important to follow up CBC every now and then for the patient so that uh, we are not faced with aganocitosis for that patient, which is very serious for them. Uh, okay, so when we are thinking about the characters of the ideal antidepressant, which is not there yet because the ideal antidepressant is not available to the moment. We hope to have one have rapid onset of action because most of the antidepressants that is available right now works after, let's say, not less than 10 days before it starts working because of most of the antidepressants available are working presynaptic. So it takes some time to be available postsynaptically. So this is one of the things that are delaying the onset of action. Also, it to have an intermediate half-life because some of the medications that are available are either their half-life is very short or very long. So to have one in between. Also, to have defined therapeutic blood level because most of the antidepressants available right now, they don't have, we cannot monitor them and the blood level. Uh, of course, we hope that it has no side effects, but uh, we were taught by one of our great pharmacologists in Egypt, uh, الله يرحمه Dr. Salah Abdel Tawab. He taught us that drug with no side effects has no effect. So mostly there will be some sort of side effects, but at least to have minimal side effects or minimal drug interactions, lower toxicity associated with overdose, which is mostly most of the SSRIs are safe in this regard, and that's why we are training colleagues in other specialties that they easily can give SSRIs because it doesn't need monitoring and it doesn't need to be tapered as for the mood stabilizers, especially the uh, lamotrigine and Tobamax. These need to be tapered very slowly up and down. When we are starting, we need to give uh, very low doses and gradually increase the dose because lamotrigine might have very serious side effects called the Johnson syndrome, and the Tobamax as well. If suddenly increased, it has side effect. Also the hope is that we have a broad spectrum antidepressant. It's very important to have one of these criteria for our ideal antidepressant. Why the people are different in their effect for different patients? We notice this that some patients might improve on some medications, others might not improve on them. Some patients might improve on low doses, and others might improve on very high doses, even beyond the therapeutic window that's advised by the manufacturer. Why are these changes are there? It might be because of genetic reasons. It might be related to hormonal changes. Might be related to the disorder itself and to the environment. As I mentioned before, there are some drug-drug interactions. So diet might be affecting the medications. Also temperature. It's very important to take care that in hot weathers not to give some of the medications, like I mentioned, lithium, for example, or one of the all the antipsychotics. Also, some of them are dangerous to give in hot weather, so it's better to avoid that. Exposure to inducers, other medications that might induce metabolism of the medication might also affect the metabolism of the drug, and this might affect the end product end outcome of the medication. Any questions till now? Okay. Uh, Talking about antipsychotics, um, what was the name of the it's divided into typical and atypical, or conventional or atypical. The typical antipsychotics are the older ones that are they started to the first one of them was discovered was chlorpromazine, and that was discovered in the 50s. And then later on, after that, they discovered haloperidol and many other antipsychotics like stilazine, trifluoperazine. But these are having very serious side effects. Some of them, like haloperidol, it might, one of the side effects might be tardive dyskinesia, an epileptic malignant syndrome, where there is what we call it, we call malignant hyperthermia, or sudden death. So these conventional antipsychotics are very limited to be used, and usually the people who use them are old people like me, because the younger generation mostly they are not using them, and they are not exposed to them, and they are being scared because of the several warnings that we give and the drug companies give for them. But still, they are very effective if monitored properly. It might be very effective in treating our patients. The atypical antipsychotics, so, the typical antipsychotics usually works mainly on dopamine. It has anti-dopamine effect that works on inhibition of dopamine. And that's why it has extrapyramidal symptoms. But the atypical antipsychotics usually works through two receptors, like working on serotonin and indirectly affect dopamine. And that's why it has less side effects. One of them is aripiprazole. It works on dopamine as a partial agonist for dopamine, so it modulates the dopamine level in the brain. The psychotic symptoms usually happens because of the increase in dopamine in an area, the limbic system in the brains, and the negative symptoms usually because of the hypo availability of dopamine in the frontal cortex and prefrontal cortex. The partial agonist effect of aripiprazole uh, make the increase on dopamine in the limbic system to be reduced, and the decrease in the prefrontal cortex of dopamine will be increased. So it modulates, they say it's dopamine modulator. While the other atypical antipsychotics like risperidone, olanzapine, clozapine, and seroquel, quetiapine, and zabrazidone, these are mostly works on reducing dopamine levels through uh, uh, serotonin, not directly dopamine. It works in serotonin, then it affects dopamine indirectly, and that's why they call it atypical. Uh, then talking about anxiolytics. Anxiolytics actually they have some different group for medications that works on anxiety. Uh, some of them are working directly, like benzodiazepines, and the benzodiazepines that are available here are divided into short-acting or short half-life or and quick onset medications like alprazolam, Xanax, or lorazepam, Ativan, or long half-life with quick onset like diazepam or Valium, uh, and long half-life but slow onset like Rivotril or clonazepam. The other non the medications that works on anxiety, uh, uh, second class of them is non-benzodiazepines, and this is only buspirone, and buspirone is sort of SSRI, but uh, it's very have very weak effect regarding the serotonin elevation. So it works as anti anxiety, and it's unique in that it's anxiolytic, but it's not causing dependence. The previous ones that I mentioned, most of them, if not properly given, then it might lead to dependence. If these medications are given on increasing attitude, like the patient after some time, after taking the, let's say, zero point 0.5 milligram of alprazolam, after some time, the patient develops tolerance to that dosage. So to get the same effect, you need to increase the dose. And if this happens frequently, he will be dependent on it. And if continued for more than 3 months, then it will be very difficult to stop it. So usually what we are doing, we are not increasing the dosage. We might change the anxiolytic to another one.
Non-benzodiazepines.
Sorry. So the for example, as I mentioned, if we are giving, for example, alprazolam, and the patient is developed tolerance to that, we might change to another one like lorazepam, or we give some holiday for a few days, then we resume it again to get the same effect. And it's advisable not to give for long period because it might lead to dependence. But buspirone is a non-benzodiazepine. It's an anxiolytic, and it's not leading to tolerance, and it works uh, in a good way to anxiety. Of course, if the patient starts on benzodiazepines, it will be difficult to switch to buspirone because it's an SSRI in a way. So it takes time to start working, while benzodiazepine works within few, let's say, less than an hour. It starts working for alprazolam and lorazepam. The third class that works for anxiety are SSRIs, which are used to panic disorder and social phobia and general anxiety disorder. Zolpidem is a non-benzodiazepine, but it's a sleeping bed. It helps indirectly for that. Some antihistaminic might be used for acute anxiety and agitation. Uh, Talking about stimulants, uh, of course, we are giving stimulants to patients who are suffering from ADHD, mostly ADHD. Some patients who are suffering from narcolepsy, uh, where they have frequent lapses of sleeping during the day, and depression. When patient is negative, lethargic, then we might potentiate the effect of the antidepressant with a stimulant medication. But if patients are not suffering from ADHD or narcolepsy, we need to be careful because they might be dependent on the stimulants. Stimulants that we have in MRS are many. We have methylphenidate. Its short acting version is called Ritalin, and long acting called Concerta. Also, the dextroamphetamine, it's trade name Adderall. We have other like dexamphetamine. It's called Vyvanse. Uh, so these are uh, the stimulants that are available in here. As I mentioned, there might be increase in blood pressure. It might induce tics. It might uh, lead to appetite suppression. So we need to take care of when we are giving these medications. Talking about dementia medications, we have many medications for dementia. Now we have donepezil, memantine, rivastigmine, and galantamine. All these medications are helping uh, in reducing the speed of dementia. It's not stopping dementia. It's not regaining uh, the level before starting the medication. I mean that if a patient develops dementia and some of the cognitive abilities are reduced, you cannot regain those cognitive abilities. You can only reduce the speed of increasing in deterioration in the cognitive abilities of the patient. Uh, Sometimes we give anticholinergics. Anticholinergics might be used because of the extrapyramidal symptoms that might happen because of the medication, or it might be given for patients who are suffering from Parkinsonism. Uh, as I mentioned, some of the old side effects of the old antipsychotics might be extrapyramidal symptoms or the acute dystonia. Uh, but also still, it might happen in even some sensitive patients in some cases who are given the atypical antipsychotics, and even some patients who are given uh, SSRIs, and a bit maybe strange, but it might happen. Some patients who are given Brimbran, metoclopramide might have also uh, an extrapyramidal symptom. So we need to check for that, and maybe we can give them the medication for that, like benzotribine or diphenhydramine, and many other anticholinergic medications that are available. Some of the medications that we can give for substance abuse management that will reduce the craving of the patient, or if we're talking about reducing the craving for the um, alcohol or heroin, naltrexone will do that. But disulfiram, I don't think it's available till now, but it works in a way that we call aversive technique, where when it's given to the patient, if he consumes alcohol, then you will have the withdrawal symptoms that will keep him not to use it. So it results in flushing, increase in blood pressure, and increase in heart rate and anxiety, and he feels as if he's going to die. So they stop taking alcohol if they have this used. It was here, and when I came to Emirates 30 years ago, it was used as an implant. They put it in the back side of in the patient back, so he cannot be removing it easily. So if he drinks, he will have those symptoms. So he will not. But it's in a way, it's not. Sort of يعني it's unhuman to do that and I don't think that it's used anymore in this way. But there are other medications that are available like Subutex and many other medications, but the most available is naltrexone. It's the name trade name Rivia. Uh, so I think this it's very difficult to summarize the all psychotropic medications that are available, but I tried my best to just to went through all of them as fast as possible. I hope I was not very fast, and I hope it was not annoying in presenting them to you. Thank you very much.
And thank you so much, Dr. Medhat, for an all-encompassing lecture and an overview. And no, I don't think it was too much. It was something we as dermatologists, personally, it's something new for us. So we really enjoy any tidbits, any introductions to it. So thank you so much, Dr. Medhat.
Thank you.
Dr. Dimitri, do you have any input or any recommendations? Can I ask a question, Dr. Medhat?
Sure.
From the dermatologist side, since we're trying to pitch this. So, of course, I know some of these medications are also used to treat some of our psychodermatological conditions.
Yeah.
So, uh, is there anything a dermatologist can prescribe or write from these lists allowed or approved as dermatologist to write, even if for like safely for like short periods or short doses? Say so, for example, maybe in like I know in body dysmorphic disorder we can write SSRIs. Can we write them, or is it preferred better not to jump specialities and just refer them to yours truly, to the
Mm,
experts, and they're the ones who start from the very beginning?
Yeah, my hope is that you have the these privileges are not specified by me or by other colleagues according to DOH regulations that some of the medications should be written by.
Every
For
physician.
example, I can't write some of the medications that you prescribe. I'm not allowed to do it. But
Mhm.
personally, as and according to WHO, many of the medications you can prescribe, and it's one of the things that we are going to have. Uh, a training in REM neuroscience for non-psychiatrists about different management of different disorders, psychiatric disorders, according to the program initiated by WHO for non-psychiatrists. It was called a GAP, um, closing the gap, something like that.
Yes.
Because of and I know that psychiatrists will never be possible to treat all patients who are suffering from mental health issues.
Of
Because
course.
if we're talking about this, it's beyond the capacity of the number of psychiatrists available all over the world.
Mhm.
Uh, Definitely, SSRIs, it's safe to be prescribed by all specialties, and even GPs are allowed to write them. But the problem is that it depends on the regulations that they are giving. Some other medications, like as you mentioned, body dysmorphic disorder, sometimes, yeah, they will benefit from SSRIs, but sometimes it has some sort of psychotic features, so they might need antipsychotic, for example, to be given to them.
Mhm.
But definitely, SSRIs uh, are possible to be written by non-psychiatrists, and I think it's allowed for uh, most of the people. They can write it. Cymbalta, for example, can be written by a neurologist, and all the medications of dementia can be written by neurologists. But unfortunately, according to the regulations, for example, sometimes I want to give some medication for the patient because of side effect of the antidepressant. Maybe you need to give them, for example, some like tadalafil or sildenafil, Viagra, or then it might not be allowed to give, or it will not be covered by insurance if you write it. But if it is written by a urologist and with some diagnoses like prostatic hyperplasia, then it will be covered. So this is the trick that we are obliged to do because of insurance issues and the DOH regulation for medication.
We have to jump through hoops. So I see
Uh,
Dr. Ines is also saying that
the
she wants to
same.
ask the same question. Yes. So do we have any first aid treatments that we dermatologists can safely prescribe? So I think that you answered this question, Dr. Medhat.
Yeah.
If you have
But
any
yeah,
other
but
questions.
if I think we did that before, me and Dr. Dimitri. But I don't know, is it he wrote for some patients. I'm not sure if I'm right or not, but he can correct me. Some patients can give them SSRIs.
Yes.
But when we had some difficulty to write antipsychotic, then we arranged with one of our colleagues who can join Dr. Dimitri in the clinic and write
Mm.
for example, aripiprazole for that patient because of having some psychotic features accompanying this. Sometimes,
And then
the like delusional infestation or something like this, you will need to give. We have a case called this sound like. Yeah, what was the name, Dr. Dmitry? I am
For
demented.
delusional infestation.
Yeah, this infestation, delusional infestation, and the other case that we have, for example, some patients who are having body dysmorphic disorder, but it was delusional, so we gave antipsychotic as well.
Right.
Yeah,
Right. Well, that's absolutely, if you allow me to add,
of course.
because it's usually when we're discussing psychopharmacology, especially between dermatologists, that question almost always coming one of the first. Is it allowed dermatologists to prescribe? Uh, there's two sides of this question. One is it allowed by authority, and other is it possible for yourself? Are you competent to prescribe? So I would like to give two suggestions. First of all, make yourself competent with one, maximum two medication for each group, the group which Dr. Medhat present. And especially as he advised, start with SSRI from antidepressant. It's considered as a safest. And the second advice, what I'm to give you, ally with some psychiatrists. Make some good relation like I have with Dr. Medhat and always can disturb him with questions for different
No, no,
patients.
you are always honoring me by your support. Dr. Dimitri is the greatest support to me and my family and my friends. We
But
always bothering him. No, he never bothers me, but I'm always bothering him.
speaking again absolutely professionally, I am prescribing myself antidepressant. I am prescribing also some antipsychotic. What is important? It's important to relate your prescription with proper diagnosis. This is what you can check in advance.
Yeah.
And the other thing is, a dermatologist, I'm not allowed to prescribe the dosage and the time duration which is allowed from psychiatrists.
Yeah.
For example, my patient with delusional infestation, I can prescribe risperidone just for 2 weeks. And to psychiatrists, correct me, Dr. Merhat, if I'm
Yeah.
wrong, but psychiatrists can give for a few months even.
Yeah, you can give for maximally 1 month in a time, but you can refill for it. So you can give him for 3 months,
Right.
but he will come every month to get it from the pharmacy.
Right. But as a dermatologist, I can give maximum 2 weeks, and after that, have to see the patient again. Of course, I'm doing this prescription in the patient which are monodelusional condition, and there is no other complication. If there is such, I prefer to discuss with psychiatrists, eventually to refer there. But again, this is my advice. In addition to having good relations with psychiatrists, make yourself familiar and start prescribing one product, at least for few patients to get experience, preferably SSRI from antidepressant, and then you can go to other groups on the same way. As
Uh,
Dr. Lukat mentioned, in most of the world, GP prescribing antidepressant and other psychopharmacological product, so there is no reason other specialty not to be allowed.
yeah.
And
Also,
thank you.
one more point, Dr. Dimitri, just to highlight that in your notes, so that if uh, they are auditing or something like that, you find that, yeah, there is the diagnosis related to that, and in the note you mention the details about this disorder that you are diagnosing. Then I think it's as far as you put the diagnosis and the medication, there is no problem, but only the duration that allowed for the GB is different than the specialist psychiatrist and the consultant psychiatrist. GBs are allowed to give for a week. Uh, the specialist psychiatrist allowed to give 2 weeks, especially if we're talking about benzodiazepines and controlled medications. Consultant is allowed to give for a month and can repeat several times up to 3 months medication.
Thank you so much, Dr. Met. Thank you so much, Dr. Viti. Reminds me also for a certain issue, of course, it's similar. It's not the same specialty, but for instance, one time I was writing for herpes zoster pregabalin for the neuralgia, and neuralgic pain. And I got similar issue where I got an error and it was canceled from the file because it was more of a wording. It wasn't allowed in the system for pregabalin for herpes zoster, but it was allowed for post-herpetic neuralgia. So I just had to specify the exact diagnosis so I can be allowed to write the medication, even
Yeah.
though clinically it's the same thing.
Yeah.
So thank you so much, Dr. Medhat. Thank you so much, Dr. Medhat. Can I have one more question, Dr. Medhat, if
You are
time allows?
welcome. You are welcome. Yes.
Okay. So one last question. So considering the slide on side effects, so this is another issue in psychodermatology. The cutaneous side effects which we see from psychological or psychotropic medications. So you mentioned lithium causes acne, lamotrigine and topiramate causes Stevens-Johnson syndrome. So in your experience, in your idea, is there any certain medications we should be wary of? So if a person comes to us and says, so he has a drug eruption, Stevens-Johnson syndrome, is there
Mm.
a certain drug, if he has a long history of medication, is there a certain drug we should be worried about or implicated, or what's the most common drugs which we can see cutaneous manifestation from your specialist, from your side?
Lamotrigine, especially when it is initiated fastly, it might lead to Steven Johnson. In my life, which is in psychiatry, I'm 37 years working in psychiatry. So I saw one patient who had this uh, lithium, induced Stevens-Johnson syndrome because of lamictal or lamotrigine, and it was because of rapid introduction of it. Usually we give 25 milligram, and after a week we increase to 25 milligram twice daily, and so on till we reach the dosage. Sometimes neurologists are faster than us because it's anti-convulsant, but we need to monitor that because it might be very dangerous. Also, talking about other side effects, lithium, for example, I noticed that patients who are taking lithium, they have sort of uh, when you see their skin, it looks like scaly skin, and they have like hyperkeratosis in their feet. Uh,
Deformed.
yeah, so this also one of the things that we notice. Sometimes patients who are taking medications that many of the medications that we prescribe causes dryness. As secondary for this dryness, there might be some uh, disorders related to, cutaneous disorders because of this dryness, because of our medication.
Mm, Thank you so much for the reply. That's amazing. Oh, always prescribe moisturizers for all
Thank you.
psychiatric patients.
Thank you very
Uh,
much.
Thank you so much, Dr. Mehmet. Anybody else has any questions before we shift to Dr. Lamia? Any other input or any other input? Okay, so if anybody has any other questions, you can put them in the chat box and we can review them later. So if you don't mind, Dr. Mehmet, if you don't mind, Dr. Dimitri, can we go to Dr. Lamia now?
Sure,
Yes,
it's
yes.
thank
As
you.
you said, if other question can be put on the chat box, or even after Dr. Lamia, we can have discussion for the two talks again. I
Perfect.
believe Dr. Mithat will stay with us.
Yeah, yeah.
Amazing. Thank you so much once again, Dr. Mehmet. It
Thank you
was
very
an
much.
honor.
Thank you.
And welcome back, Dr. Lamia. It's an honor and a pleasure. So let me introduce you real quick. Dr. Lamia Mubarak is a dermatology specialist, part of AHS, Siha UAE, is with 5 years of experience in diagnosing and management of a variety of skin conditions, and holds an MD in dermatology from the Sudan Medical Specialization Board. She has extensive experience in skin health and advanced dermatological practice. Currently part of HS Siha, focuses on delivering comprehensive personalized care to her patients. She's passionate about advancing dermatological care, and we are excited to have her with us and her initiative. She'll be giving us a very interesting titled lecture, Beyond the Surface, Healing Through Science and Mind. So the floor is yours, and welcome, and mic is yours.
Thank you so much for giving me this opportunity. Are you hearing me well?
Perfectly well, yes. And we can see your slide.
Okay. So let me tonight to take you in a journey of healing through science and mind, and to enhance the dermatological outcome for our patient, to improve the quality of life, and just go beyond the surface of the skin and dig deep to see what is going on. So why this matters? Why this matter? Because we know that most, if not all, of the dermatological patient report psychological factors impacting their skin condition. We all know by now from the previous lectures that chronic stress disrupts the skin barrier, leading to inflammation, delayed healing, and flare-ups. And traditional treatment often stress or address the symptoms, but miss the underlying emotional or psychological triggers. So what if addressing the mind alongside the skin could amplify the success of the conventional treatment and improve the quality of life of our patient? Because at the end, we want a happy, functioning individual in the community. So My goal of the lecture is to introduce the concept of skin as emotional communicator and to explore the integration of traditional dermatology alongside with the mindset, mindfulness, and healing practices, and provide like an actionable tool for us as dermatologists to enhance the patient outcome. So the science, we know that, or we understand by now, the skin-mind connection. We all that both the skin affect the mind and the mind affect the skin. And we have a certain biological pathways linking stress and skin. And we know the brain-skin axis and how the stress activates the hypothalamo-pituitary adrenal axis, which lead to increase in the cortisol level. And the cortisol effect impairs the skin barrier, delay the wound healing, and increase inflammation. Also, stress lead to production of pro-inflammatory cytokines such as interleukin-6, tumor necrosis factor alpha, and the stress amplifies the inflammatory pathways and worsening the underlying condition, such as eczema, acne, psoriasis, and we know that most of our dermatological condition either exacerbated or triggered by stress. So this is a vicious circle. Also, the skin is not also the skin has a dual role. What I mean by that the skin acts as an emotional communicator, because the skin has both physical barrier and emotional communicator. What I mean that it is an emotional communicator, it reflecting our internal status. When you are happy, it's reflected on your skin. When you are sad, depressed, low mood, also it is reflected on your skin. So the emotional states such as stress, anxiety, shame, blame, guilt, regret, any of these emotions are visible in our skin. For also, it has been mentioned in Quran that in the judgment day, some faces will come black and some faces will become white. We have in Surah Al Imran, يوم تبيض وجوه وتسود وجوه, and this is reflecting if you are happy with with your deeds in this life. If you did good, this will be reflected as brightness. When you are like feeling safe, feeling confident, will be reflected on your skin. And when you did bad things, it also reflected as darkness of our skin. So means that our emotion is reflected by a way or other on our skin. And we all know that in the case of embarrassment, we have blushing and the hive and urticaria exacerbated by acute stress, and chronic stress exacerbates psoriasis and eczema. So also the skin has a cultural and psychological impact. The skin condition often carries social stigma, impacting the mental health. And in many cultures, the skin is tied to the perception of health, beauty, and mortality. And of course, we all have seen patients whose skin condition worsened due to the emotional stress and societal pressure. Also nowadays, a lot of researches are going on stressing on or want to prove the effect of mindset and mindful techniques and the relaxation techniques and breathing techniques on the hormones, on the cortisol level, and indirectly to the other skin condition, and it is especially studied in the field of dermatology. And evidence-based research, we have like a Kabat-Zinn study, and a Kabat-Zinn, it's himself is a microbiologist, it's American microbiologist, working on the mindset since 1979, and he has his own school, and he is passionate about studying the effect of mindset and mindset techniques in the outcome of the dermatological conditions and other skin conditions, as well as the effect of these techniques on the quality of life of the patient. And he had found that psoriasis patients participating in the mindfulness techniques during phototherapy cleared very faster with a significant p-value. And stress reduction interventions like meditation reduce the cortisol significantly and improve the skin condition and improve the overall quality of life. And also a lot of pilot studies on mindfulness-based stress reduction techniques show how stress reduction techniques improve the outcome of the patient, especially in diseases like atopic dermatitis, psoriasis, and even vitiligo. So what if we could bridge the science and holistic healing? Because this is very easy, very safe, zero side effect, and with a tremendous effect on the quality of life of your patient. At the end, we didn't want a miserable patient, depressed, and what if, but by using simple techniques like using the mindset techniques could improve the quality of our patient tremendously. So expanding the treatment paradigm, as I mentioned that the conventional treatment target physical symptoms, but emotional triggers remain unaddressed. So introduce healing practices like mindfulness techniques, mindset work, and energy healing can complement our traditional method, not replacing. I'm talking about complementing. So we have a lot of techniques which are well studied, well researched, like deep breathing technique, reduce the cortisol level, improve the blood oxygenation, visualization, help the patient to imagine a healthy skin, improving the emotional resilience. And we will never forget that Dr. Hanish in the previous lecture, when he teach us about the effect of visualization, even in visualizing a blood vessel going to a wart can improve the healing and lead to disappearance of cutaneous wart. So this is the power of our mind. If you can imagine it, you can see it. If you believe it, if you believe in it, you will have it. If you could imagine a healthy body, you will have it. If you have no doubt, you are able to change not your skin, but your own life. And also, he teaches us about the progressive relaxation techniques, which can improve the itch scratch cycle in eczema and in psoriasis. So we have a lot of also another techniques apart from these. We have the science of touch, which the touch reduce the cortisol and enhance the emotional well-being. And no one of us could ignore how significant hugging is affecting us. When someone you love hug you, this will change your status, your mental status, your psychological status, and your physical status. And nowadays, there are a lot of energy practices with touching certain points. These are called energetic points, which they believe that the emotions and traumas, like what happened in our life, are stored in these certain areas. What if we could touching these areas could affect our body? For example, patients with stress-induced eczema found a very dramatic improvement with topical steroid or topical treatment and energy session. Also, I would like to emphasize the breaking the cycle of no cure for our dermatological condition. And we should empower the healing, the programming of lifelong disease. This is a brief. What if we could challenge this program? What if is there more to healing? Because when you said to the patient that this is a lifelong disease, he's going to believe in it. He will not look for other possibilities. He will not search. He will not see what other possible for him apart from what we said. So, as a medical professionals, we are conditioned through years and years of education to believe in certain diseases, to believe that certain diseases are incurable and require like lifelong management, ignoring the natural capacity of the body to heal. And as Dr. Amin mentioned in the previous lecture, we had been biased. What if this is not true? What if there are hidden agenda from the pharmaceutical companies to lead us, bias us to believe that this is a lifelong disease and the patient should continue to use the medication throughout his life? So patient often told to live with the conditions like psoriasis, eczema, vitiligo, reinforcing a mindset resignation. No one will believe that other possibilities are existing in this universe. So, what is the reality check? Since I start to explore what is beyond I know, what is beyond that things we have been taught throughout the medical college post-graduation, and the fact that I discover a whole new world. Thousands and thousands of cases exist where the patient has the ability to heal themselves through the power of mindset, breaking free from the traditional medical expectation and encouraging the natural capacity of the body to heal. Every single cell is a complete set of factory. You can reset the cells to the cellular memory just as you can format your computer. You can give orders. If you believe in it, you will have full regeneration, full reset of everything in your body. So, the role of belief system in healing. What we believe shape what we see, not only in the healing, but throughout this life, in all aspects of our life. What you believe it, you will have it. So the medical model is based merely on empirical data, probabilities, but often overlook the role of the patient belief system in healing. And we all know that the effect of placebo, with the placebo effect, is a powerful demonstration of mind's ability to influence the body. So in dermatology, placebo cream shows to improve the condition like psoriasis and even vitiligo due to the patient believing on them. So what if we could invite the patient to believe in healing or just open the door for new possibilities? When we as a practitioner communicate that the disease is incurable, we are unintentionally program the patient to limit their healing potential. So if this is a vicious circle, diagnosis, believe in no cure, resignation of mental set, and then we have stress and flare up and vicious circle. The patient will be throughout his life entrapped in this circle. Imagine the quality of life, stress, depression, poor social interaction. As if he's in a trap. What if other possibilities are present? What if we could break this program, shifting the narrative? What if we were wrong? So, what we can expand our knowledge, expand our perspective. Some dermatologists, I know, even my colleague, never been exposed to concepts like healing, energy work, and mindset techniques because we had been programmed to see all these are like nonsense, non-realistic, non-scientific. So challenging our traditional thinking, I know it is not easy because maybe the last 20 years of our life or even more, we are just have a concrete scientific thinking. We never have a chance to look what is available else in this universe. So how many of us have been seeing patients whose symptoms improve dramatically with no clear medical explanation? What if their mindset and belief system play a significant role? What if the belief in no cure is limiting both practitioner and the patient? What if healing is possible when we address the root of emotional and psychological issues? So I know that the common concerns are that healing practices seem unscientific, but the present evidence-based studies validating the stress reduction technique. So during the last 4 years of my life, I have seen like magic. I see personally and interviewed patient. For example, I know one patient with severe multiple sclerosis. She was blind, she was paralyzed, she was unable to eat. She quit all her medications and started a transformational journey, setting her mind. She believed in the mindset. She believed in the ability of her body, natural capacity to heal. And guess what? After 1 year, she was able to see, she was able to walk, and her life was like medically transformed to something else. I have seen and interviewed a patient with terminal cancers metastasizing to the all part of the body with all the medication. I seen them, I interviewed them. They just start to believe in something else, believe in the natural capacity. They put aside all the medication or the opinions of their treating doctors and start just working on their belief system, on the body natural ability to heal. And like I have seen an amazing result. Me myself, I was having status asthmaticus, and I just want to explore if anything is possible. And I also work on my mindset. I choose a different reality, and guess what? It is working, alhamdulillah. So it is just open the door for a new possibility to your patient if he is willing to receive from you, if he is willing to listen, because it is a completely choice. It is the choice of your patient to decide or to choose what he is going to choose, because some patients are committed to their disease. Some patients are committed to their status. They have also their second agendas. So just open the door, light a lamp for your patient. Let them explore what is other available for them, and it is their choice whether to go to it or to commit their disease and their traditional way of living. So a real life example, as I shared with you, these are real cases. We have 40 years old man with 15 years of history of severe psoriasis, just a combination with topical treatment and mindfulness techniques with self-compassion in exercise address the feeling of addressing his feeling of unworthiness and all the feelings that he had improved dramatically just with the topical combined with the mindful techniques. And another vitiligo patient, a 35 years old woman, and also when addressing the emotion, the psychological issues which triggered or exacerbate her condition, improved dramatically with combination of these mindful techniques and the pigmentation other pigmentation methods. So breaking the programming, recognizing we have to recognize the impact of language we use with our patient. Avoid absolute statement like no cure, lifelong disease, you should live with this condition for life. And instead frame the condition like chronic but manageable with a potential of significant improvement. Empower your patient. Teach the patient to challenge their own limiting belief if they are willing to receive. And introduce practices like journaling, affirmation, mindfulness to help them to take control of their healing journey and just invite them to explore what is available for them beyond what you know and to explore a different reality. So also we have to educate ourselves and our colleagues on the alternative approaches which could improve the quality of the life of our patients, like energy work, emotional freedom techniques, EFTs, and the role of the subconscious mind in healing. Share the reflective question with them. What would change if we believe that every patient had the capacity to heal? So, tools for us. We have, if possible, if we choose, it is a choice. We have to reframe the consultation, shift the focus from managing our condition to supporting the natural capacity of our body to heal. Also, we have to just focus on our language because the language matters. We have to use the empowering phrases like your body is resilient and capable of recovery. You can explore what else is available. And also we have to educate ourselves to explore the integrative medicine techniques, including the mental health and energy healing. And mental health is a branch of medicine now, which is well known everywhere, which study the mind, body, and soul connections and how they are relating every single disease that you know to a certain emotion, like the fear, separation, rejection, childhood traumas, shame, blame, guilt, regret, everything is related to emotion. And their theory is that when you manage to find the triggering point or certain emotion, and when you deal with it, you could have a transformational change in the path of the disease. So also for the patient, for me, for example, in my clinic, when I perceive that this patient could hear or could listen or could receive from me, I just invite them. Go and search. Go and check Google, YouTube. Write, for example, healing stories in psoriasis, healing stories in eczema, healing stories. Just an invitation. And after a few months, the patient coming to me back and telling me the effect of what they have been exploring, because everyone is going to explore in a different way and to just try different modalities. So we could encourage the affirmation, teach the patient to replace limiting beliefs with empowering ones like my skin is healing every day, as Dr. Hanish teaches, and the visualization encourage the patient to visualize a clear skin, a healthy skin while practicing relaxation techniques. And also the journaling helps the patient to offload their emotions into a paper, and this is a very nice effect also. So the future is healing is possible. Healing is not just a physical, it is this is a combination of the mental and emotional uh, state. So by expanding beyond our traditional method and challenging our own beliefs, we can unlock new potential for our patients and even for ourselves, and see what are infinite possibilities that is available for all of us. I think by this I end my talk, and I hope you enjoyed it.
Thank you so much, Dr. Lamia. We definitely enjoyed it. Thank you so much for very new and very modern and very important approach. It was a pleasure. It reminds me of this quote this mantra, which I personally love, which is "You are in control." So we generally say that we are always in control of everything, of our skin, of our condition, mind over matter, like they say.
Yes.
So thank you so much, Dr. Lamia. Anybody have any questions, any input, any advice, any discussions? Me? If I can have a quick question, Dr. Lamia.
Yeah, welcome.
First of all, you mentioned a lot about breathing techniques and EFTs, emotional freedom techniques. Any specific sources, references, or advice for us personally before we give them to our patients? If you have any resources, it will be also, or references, it will be also amazing.
So for most of these techniques or energetic techniques are no definite source. So for me, as I told you, for me, even when I started to learn these techniques and practice these techniques and do it for others, also there was no like one source which I can recommend, but we have to start searching. And when you search, because these like levels, when you start to search, the level that is open to you is according to what you can receive. You understand this point? So no like not no, I have no recommendation like now go to that website or read that book, because it is a journey of learning.
Perfect, perfect. Another quick, it's more of a conundrum, more of a dilemma we face. So we're convinced that this is a new approach, but how do we convince our patients? Patients are usually, they're more rigid-minded. They're not open to these suggestions sometimes. They're coming to the doctor mainly, I want medication. I want something specific to help me. So how do we open their mind? How do we slowly ease them into this concept? Do you have any also?
Yes.
How do you do it?
Okay, first of all, we are not quitting the medication. We are just trying to improve the quality of life of the patient by adding certain things like these techniques, like mindset, like that. So the main thing is the patient selection, as I mentioned, because not all the patients are ready, not all the patients are willing to explore. So, for example, in my clinic, when I perceive that this patient, because patients also you will feel each other. So when the patient start to talk to me, they perceive that I'm different. They start to telling me their stories. If the time of the clinic for allow me, I will listen. And when I listen, at certain point, I know that at this point I can ask the patient to explore what is different available for them. For example, if they are telling me no cure, I said, "Who told you that? Did you go and search by yourself? Or you know that your mindset is poor? If you believe this, you will have it. But what if you believe something else? You will have a different result. Do you explore? Go explore, and next time tell me what you see, what you have found." So it is basically depend on the patient selection. Not every patient is willing. Some patients are committed to their like sorrow, their trauma, their drama, their belief, and also some patients are being programmed also by us to believe in certain way. So for me, it is not, I don't convince anyone. I just open the door for new possibilities, ask the patient to explore, for example, read about self-healing in like anything like psoriasis, eczema, whatever, and come and tell me. Now, I have one patient who went, after 3 months, she came back to me, and I found her finding the same resources that I have used to teach myself. Like, wow, she's reading books, she is practicing a lot of mental techniques, and her skin condition is like without medication change. She is very happy actually. So as I told you, not everyone is ready, even us. Not everyone is ready. And when I perceived that I could help this patient, I know when exactly when I start my talk or how could be an invitation, because to be an invitation is not something easy. To invite someone to new beliefs or new possibilities, they have to trust you first, and they have to perceive that something different is available.
We seed the salt, we just seed it, and we just wait for the fruit to bear. So
Yeah,
fantastic. We recruit them into the journey. Thank
yeah.
you once again. I see Dr. Huda has a question. It's more of a general question, of course. Anybody's free to answer. With the limited time we are offering patients in our consultation, how can you address the psychological needs for the patient? So I think Dr. Lamia, Dr. Medhat, Dr. Dimitri, anybody can answer this question. The floor is yours.
Yeah, please, Dr. Lamy, I'm interested to hear your explanation, please.
Yes, I think I am very well trained, or I train myself, I teach myself. I have the ability to sense what is the problem of this patient, what is the root of his condition. Even from a single few words, I have this. I had been training myself, reading a lot, and I think since the patient opened his mouth, I know what is their issue, what is their underlying condition. I think, but even with that, during very busy clinics, I know that I could help this patient, but the time limit is very frustrating for me. But I know that I'm going to see this patient, for example, in the follow up, and another day. I on purpose give them appointment on the days that I know it will be like a light, and ask them to come early or give an early appointment when I know that the clinic will be like light, and I talk with them. Even if if the very busy clinic, and when I perceive this patient could stop from anything else other than the medication, I just um, you like choose certain point during his talk and just like try to like shake his belief system. What else is possible? What if this was not true? What if another reality is existing? And like suddenly, like, what do you mean? I mean, like this, just few seconds, 1 minute can change the patient's life. Yesterday I was doing, for example, Botox, and the patient was, during the Botox procedure, she was telling me that she's very young, have rheumatoid arthritis, lifelong. Just I said, what if also possibilities existing for you? Did you explore? Did you search? Or are you committed to this reality? Or you can choose something else? Like she was standing in front of my door. She just want to talk to me. Although I'm very busy. Doctor, can you give me like a books, website? Go and read, go and check, go and explore. It is not an issue of time. It's like for me, it is an issue when you perceive that this patient could benefit from you, and when you know that even 1 minute from your time could change the whole reality or reality of a patient. I think it is going to be like a second nature. It will be something spontaneous.
That's really great. Thank you so much, Dr. Lamia. Unfortunately, with growing pressure for productivity, overbooking the patient, having, I cannot recall all terminology, even this parallel clinic, which maybe it's some kind of mystery for some, but with this, I think having enough time with the patient will be more difficult. But anyhow, we should not give up. And what Dr. Lame say, you have to call the patient for other consultation. You have to maybe sacrifice some of your personal time. Well, it's maybe not for every patient, but for selected cases. I want to use opportunities in speaking to thanks Dr. Lamia for her talk, and I like very much what she said, that some of patients are programmed by us. That's very true. Sometimes we programming patient unconsciously even, but I believe Dr. Lame is capable to reprogram the patient on the good way, something what will be beneficial for them, for their family. And this is maybe one point to invite Dr. Medhat mentioned that they have special program psychiatry for non-psychiatrists. This is one good point to invite most of the colleagues who are dermatologists maybe to attend in these mental health programs for non-mental health professionals in order we to learn more and to practice more in our clinic. Thank you, Dr. Lame.
Thank you so much.
Sure, it will be our pleasure. I'll share with the group the dates for the presentations that we will have. We're going to have the first presentation will be about first aid psychological tools. So maybe it would be nice to attend, and it would be our great pleasure to have you with us.
It would be an honor to attend. We would really look forward to it. Thank you so much, Dr.
Thank you.
Okay, so any other input, any advice, any other questions? Dr. Dimitri, Dr. Medhat, Dr. Lame, do you have any final words or anything else you need to add?
Thank you very
From my
much.
side, no, thank you. Thank you for the two speakers into discussion. Thank you very much.
Thank you very much for your invitation and for all your encouragement and your persistence in spreading this initiative, and looking forward for more in the future, inshallah.
Thank you